So this is the second part of our thyroid ultrasound lecture. Here there's a young female student. The incidental finding is that she has 3 nodules on both sides. The one on the right lobe is homogeneous with regular borders and hypoechoic structure, so it is a Thyroid's 4 nodule. The ones on the left lobe are, one of them is cystic, little bit complex cystic, and the other one has macrocalcifications. It is hypoechoic with irregular borders, and it is Thyroid's 5. On Doppler, you see that the Thyroid's 5 nodule is hypervascular. The pathologies turned out to be, the one on the right is follicular cancer, and the one of the nodules in the left lobe is papillary cancer. In medullary cancer, we can sometimes appreciate the distal attenuation due to amyloid deposition. And we know that in these patients there is striking calcitonin rise. In this patient, who is 43 years old male, you see the big nodule and the thyroid. It is very hard, and you can see the distal attenuation. And on the right side, we see a big lymph node, which is metastatic, which proved to be metastatic in this patient. And an example of anaplastic cancer in a 58 years old male. On the left side, you see a hypoechoic, big, irregular nodule, and we see that there is left jugular vein invasion in this case. In this longitudinal view, you can appreciate how big the anaplastic cancer is. And in the same patient, you see the jugular vein without any flow, and you can see the big mass, which is a metastasis. So, to conclude, we of course see most often papillary thyroid cancer, and it is approximately 80-85% of all thyroid cancers. And next comes follicular thyroid cancer, which is 10-15%, and then comes the medullary type, which is almost 4%, and anaplastic cancer is probably around 1% or less than 1%. How do we detect the recurrences after treatment in thyroid cancer? Of course, ultrasound is the first method, but of course you should add the laboratory test. Thyroglobulin should be checked in the controls. This is a young female with papillary cancer who was operated 3 years ago, and now there is recurrence. You can see the recurrence as a hypoechoic nodular mass with punctate echoes inside, and there's also an accompanying lymph node, enlarged lymph node in the left side. If we look at the cancer mimics and cancers that develop on thyroiditis base, this is a 79-year-old female who has a nodule, big nodule, 8 millimeter nodule. The gland is small, atrophic, because she has Hashimoto. This nodule was stable throughout many years, so it's a benign nodule. This is 42 years old female, and she has a suspicious 12 millimeters Thyroid 5 nodule in Hashimoto base, and the aspiration biopsy resulted with benign findings, but there was still suspicion, and because you see that the mass is not very small, it is very irregular, very hypoechoic, has vascularity on Doppler mode, so it is taller than wide, and it was operated, but still it turned out to be a benign nodule on Hashimoto base. This is a 58-year-old female and has a similar Thyroid 5 nodule, stable for 5 years on Hashimoto base. This is a similar case, and there is Hashimoto in this patient. There are multiple Thyroid 5 nodules, and they turned out to be multifocal papillary cancer. You see again a taller than wide nodule with punctate echoes, very hypoechoic, irregular borders. So sometimes we cannot differentiate these nodules, the benign ones from the malignant ones. This is a young male patient again who has a typical Thyroid 5 nodule on Hashimoto base. You see the nodule on the right side. It is very hard and it's papillary cancer. Another patient with Hashimoto, the typical taller than wide nodule with punctate echo inside. It's quite hard. It's Thyroid 5, and this turned out to be papillary cancer. It's 9 millimeters. This is a 64-year-old female with a Thyroid 5 nodule, as you see here. Very irregular borders, very hypoechoic. The cytology was benign, but the patient has lung cancer, so the patient was quite suspicious. It was operated, and post-op pathology was decurvain. So we know that decurvain may be mistaken, the hypoechoic nodules may be mistaken for malignancy in decurvain disease. This is also a young woman with suspicion of papillary cancer, but it turned out to be decurvain on the final pathology. It's not a typical decurvain. The nodule is small and suspicious. But sometimes the opposite may happen. So this is a case like that. It's 42 years old female with a hypoechoic Thyroid 5 nodule. There is decurvain thyroiditis in the patient, but one of the nodules is 9 millimeters papillary cancer. This is a Graves' disease. The patient is 44 years old, female, and there were several nodules, and it turned out that these nodules had malignancy on in them, microcarcinoma of papillary cancer. If we look at the pediatric cases, this is a 4-year-old boy with diffuse bilateral microcalcifications. So it turned out to be hobnail variant of the papillary cancer. You see the heavily calcified or a nodule with multiple microcalcifications, and there are supraclavicular lymphadenopathy in this patient also. This is a big nodule of 3 centimeters in a 5-year-old female, so we should always feel more suspicious. It's different than it is in the adults because the proportion of malignancy is quite higher in children. The thyroid nodules in children have almost 20% malignancy risk. But, however, sometimes, only in the pediatric age group, we see some ectopic tissues that may look like papillary cancer, and these are usually thymic tissue within the thyroid tissue. So, ectopic tissues may be seen in the thyroid. Most common is the thymic tissue, but parathyroids may be within the thyroid, and very rarely lymph nodes, salivary tissue, bronchial cleft cysts, and thyroglossal duct cysts may be placed within the thyroid tissue. This is a lymph node, you see, within the thyroid. This is a lymphadenopathy within the thyroid gland in a 77-year-old female. This is a thyroglossal duct cyst within the thyroid, and there's an accompanying thyroid-free nodule in this young patient. So, to summarize, we have some common differentiation problems, and these are still unsolved. We cannot always differentiate colloid from microcalcification. Sometimes we can see the comet tail artifact distal to the colloid, and then we can be sure this is colloid. But sometimes within the tissue, squeezed within the tissue, colloid may not give comet tail artifact, so we cannot differentiate them. We must call them punctate echoes. And the second problem is cystic nodules with solid components. We cannot always say that these are benign because the solid components may have papillary cancer components. The third problem is in children. Sometimes ectopic thymic tissue may be considered as microcalcific nodule. We should keep this in mind. This doesn't happen in adults. And in the acute vein subacute thyroiditis, the hypoechoic areas may be misdiagnosed as malignant nodules, but we should be careful and follow up because sometimes the two events may coincidentally be seen in the same patient. So I can show you some rare images and cases. Sometimes we can see the disruption of the capsule, but this is not very common. We cannot always be sure if the capsule is invaded or not. But this is a case with capsule invasion. You can see that the nodule invades the capsule, interrupts the echogenic capsule. This is a 49-year-old female with a nodule in the left thyroid lobe. Of course, we should always keep in mind that we can have metastatic nodules. This is a 5 centimeter big metastatic nodule from breast cancer. Usually, the metastases from to the thyroid come from melanoma, breast, or renal cell cancer. This is another rare case with calcification, but it is like ossification more than calcification. So this is osseous metaplastic adenomatous nodule. Sometimes the papillary cancer may present, or thyroid cancer may present with bigger cervical lymph nodes than the primary nodule. This is such a case, 59-year-old male with big conglomerate lymph nodes that seem to be necrotic, and the nodule in the thyroid is smaller. Sometimes, very rarely, we can see abscesses. This is such a case. He's a male, 39 years old, and you can see that the vascularity is only around the nodule. Inside there is no vascularity, so this was a thyroid abscess. Thyroid elastography is very helpful to us, but it is still not used in the guidelines. It does not change the status of the nodule. I mean, if it is hard, it can still be benign. If it is soft, it can still be malignant. So, but we can say that the elastography findings are in favor of benign findings. And contrast use in thyroid nodules is quite limited, and it's not practiced worldwide, but it can be helpful. The last part of my talk is about reporting. The reporting is as important as imaging, because there's a pandemic of thyroid nodules, there's a pandemic of biopsy of the thyroid nodules, and there's a pandemic of thyroid cancer because of these. In a 2016 study, the authors found that overdiagnosis of thyroid cancer, which means the diagnosis of thyroid tumors that would not, if left alone, result in symptoms of death, accounted for almost 80% of thyroid cancer cases in women and almost half of the cases in men in United States in the last years, recent years. And our reporting, whoever is doing the thyroid ultrasound, the radiologist, the radiology sonographer, or the endocrinologist, or the internist, or the surgeon, the report should be sufficient, should describe everything, and not only description of the nodules, but a classification, stratification using one of the guidelines or the TI-RADS classification systems, and there should be a conclusion at the end of the report, and there should be a suggestion at the end of the report. We can choose not to follow up, no need to follow up. The nodules may need follow-up, or the nodules may need biopsy. We should all comment on these. Let's look at the problems of the ACR, American College of Radiology TI-RADS system. For example, one problem is that for same solid nodules, decision should be based on the solid component, it says. However, I believe that Doppler is neglected here. It's very valuable for complex cystic masses. For example, in this case, you can say confidently TI-RADS 2 if you use Doppler, because there is hemorrhage in this complex cystic mass, and it's not a solid suspicious part. You can follow it up, or you can see the blood level, and then you can be more confident that it is one. The second problem is in some TI-RADS 4 cases, for example, 9 mm TI-RADS 4. It's quite suspicious, but follow-up is not suggested in the guideline. So I believe that such a nodule should be followed up. Another problem is that sometimes we may have followed up some nodules, hemorrhagic nodules, and they may end up with a smaller TI-RADS 5 nodule. Then we should not do anything for these nodules, because we know that, for example, in this case, 2 years ago it was a hemorrhagic big nodule and it became small. The resorption of the hemorrhage made it smaller. So we should not biopsy these cases. We should keep in mind that some big hemorrhagic cystic nodules become smaller and look like thyroid 5 nodules. So the report format should include the history, the family history, personal history, the former FNA results, and in the results section we should talk about the thyroid dimensions, volume, echogenicity and vascularity of the gland, not only the nodules. Then we should describe the nodules, all properties of the nodules, and we should check the lymph nodes, and then we should conclude, as I said, we should suggest something for the patient. Many clinicians, of course, point out to the, again, mortality rates unchanged despite the increase in thyroid cancer. So the cancer is increasing, the biopsies are increasing. For example, almost half of the thousands of biopsies in the United States have been found that most of them are not necessary, in fact. To avoid this, the reports should be carefully evaluated, because the clinician's interpretation of ultrasound report, especially if specific high-risk nodal characteristics are not commented, then it's not very valuable and it may lead to unnecessary biopsies. So the risk classification of thyroid nodules should be done, and it has been started in 2005. The first thyroids paper came out in 2009, and till now many thyroid classifications have been created, the first being Korean, and now which are in use, which are most popular? Yes, the ATA criteria or guidelines and ACR thyroids guidelines are the most used, most popular ones. This is the ACR guidelines. You can find it and you can use it in practice. But we should again keep in mind that even the thyroid 5 nodules don't have so much cancer risk. Almost 2/3 of thyroid 5 nodules end up benign. What is the difference between the thyroids, ACR thyroid system, and the American Thyroid Association 2015 guidelines? Biopsy threshold is lower in ATA guidelines. What are the follow-up rules as commented by ACR, American College of Radiology, in 2017? Annual follow-up is recommended, and a certain period of 3 to 5 years is usually recommended, and significant enlargement criteria is taken as 20% increase in 2 dimensions and 50% increase in volume. Coming to the end of the diagnostic part, I should mention the treatment part also, because ultrasound is also very valuable in guiding ablations of the thyroid nodules, even if they are cancer. Initially, ultrasound guided ablations were applied for benign, big, or autonomous nodules. But in recent years, now ultrasound guided ablations are considered for malignant nodules. First, they were indicated for nodules less than 1 centimeter, but now they are even applied without size limit because the results are quite encouraging. What ablation methods are used in thyroid? Of course, historically, maybe in the last 20 years, thermal ablation, radiofrequency ablation has been the most popular, but nowadays microwave and cryoablations are also used. This is a recent case that I have seen in my very soon interventional radiology clinic. My colleagues are doing cryoablation for a 2 centimeter papillary cancer. Here you see the nodule with punctate echo. During the ultrasound guided ablation, you see the ice ball formation, and we can be sure that all the nodule is ablated. So this is a quite new and quite effective method. So we can summarize our talk as you see here. Diffuse thyroid diseases can be differentiated mostly by ultrasound, but you must keep in mind that you cannot always differentiate them, especially sometimes Hashimoto gravis at the initial phase at least. But we have some clues that we can use. Nodules in a normal gland or in thyroiditis, heterogeneous multinodular base should be described in detail and categorized and followed up more carefully. Thyroid systems and ETA descriptions have similar common points. One of them or any other institutional modification should be used, and it should be stated at the end of the report. The role of ablations for both benign and malignant thyroid nodules is increasing, and surgical methods are decreasing. So this is the end of my talk, and you can follow my YouTube channel, and this is the address of my website, and you can mail me about your cases and interesting questions. I'll be happy to answer them. Thank you for listening. Bye.